سم واضح الآن؟
خلاص نعم بدأ التسجيل. بسم الله، مرحبا بكم يا دكتور، تفضلوا.
طيب يلا بسم الله الرحمن الرحيم. يعني this يعني talk أولا thank you very much for asking me to participate in your activity and very pleased to be يعني with you this night. And as I said, probably tonight we'll talk about approach to pediatric vasculitis. It will be like talking about like interactive session. I will just give a brief background, then I will present few cases. Feel free to interrupt me at any time. And I think this should be helpful for daily practice. Let me start with this question. We heard a lot about vasculitis, and sometimes we heard about vasculopathy. So is there a difference between these two terms, or it can be interchangeable? Probably we use it as arthritis and arthropathy. We use myositis and myopathy. So there is some changes, but let me give you a hint about definition of vasculitis. It is an inflammatory destructive process affecting blood vessels, requiring inflammation within vessel wall. Means there you should see, or the histopathologist should confirm there is inflammatory process in the vessel wall, means inflammatory cells there. It may include infiltration of the vessel wall by inflammatory cell without destruction. So there is two components, the infiltration with inflammatory cells, or maybe an addition findings, which is destruction. It can be complete destruction or partial destruction. This process may compromise vessel wall, leading to ischemia of the corresponding organ. Now, this definition is non-specific. Vasculitis, the definition. Now, vasculopathy means there is abnormalities in the blood vessel. It can be inflammatory, it can be non-inflammatory. We heard a lot in adult with atherosclerosis. We heard about some congenital malformations in the blood vessels. These considered as vasculopathy, but it is not vasculitis because no inflammatory cells in the blood vessel wall. Now, it can be the vasculitis, it can be primary or it can be secondary. So the secondary means there is underlying disease. Primary means we couldn't find or proved any underlying cause. The secondary causes long list, including infection, including malignancy, drugs, or systemic diseases, such as systemic lupus erythematosus, juvenile dermatomyositis, systemic juvenile arthritis, and name it. So there are different inflammatory or autoimmune disease, or it can be even auto-inflammatory diseases. Now, the clinical symptoms, there is wide spectrum and it's long list, depend on few factors like the location of the blood vessels. It can be isolated vasculitis. For instance, if it's affecting the CNS, we call it primary CNS vasculitis. It can be systemic vasculitis like HSB or Kawasaki. It can be just affecting the lung. It can be affecting the kidneys and so on. So the location of the vessels is very important. Also, the size of the blood vessels is very important. It can be small, it can be medium, it can be large. By definition, if the vasculitis is affecting large vessels, medium and small vessels will be affected by default. But if the disease affecting only small vessels, maybe the medium or large vessels not affected. Let us take an example. HSB mainly affecting the capillaries and small vessels. This will not affect large vessels. While if we take a case of Takayasu, means there is a large vessel vasculitis, by definition, it will affect the small and medium-sized vessels. Now, again, the other factor affecting the clinical symptoms or manifestation, the extent of inflammation. It can be focal, it can be segmental. Also, it depends on the underlying pathology. Is it, or the pathogenic mechanism? Is it immune complex formation? Is it ANCA-associated vasculitis or T lymphocyte medium with granuloma formations? No one, it can be more than one mechanism. Now, one etiology, it can be associated with different vasculitis. For instance, for the secondary vasculitis, if we take hepatitis B or strep infection, it may induce cutaneous vasculitis, it may induce cryoglobulinemia vasculitis, glomerulonephritis, polyarteritis, and so on. So one etiology can give different vasculitis. So now, due to the multi-system nature of this disorder, ideally, multiple subspecialty may be involved in the diagnosis and ongoing management of child with vasculitis. For instance, Wegener's vasculitis or polyarteritis nodosa, it may affect the kidney, means I need nephrologist to be on board. If I'm following up with patient disease affecting the liver, I need gastroenterologist to be with me for management of such patients. So it is multidisciplinary, of course, dermatologists, of course, the ophthalmologists, and sometimes neurologists. So it depends on the organ involvement. The subspecialty may be needed according to the organ involvement. Now, it's very important the time of recognition and treatment, because if there is delay in diagnosis and proper treatment, this may lead severe or life-threatening condition or status. Now, the diagnosis of vasculitis is challenge. It's not easy because there is no specific manifestation. It can be subacute, it can be non-specific, or unfortunately no diagnostic tool, except I will come to the diagnostic or the making a diagnosis of, but there is no real diagnostic test. Now, there are certain type of vasculitis are common in specific group. For instance, Kawasaki disease, HSP, this type of vasculitis predominantly affecting children. Other type of vasculitis primarily occurs or affecting adults, for instance, arteritis. This is almost exclusively for adults. If you see and somebody labeled him as giant arteritis, this is completely incorrect. But large vessel vasculitis, it can affect children, but not giant arteritis like Takayasu, it may affect children. Now, if vasculitis is suspected, you need to take detailed history and comprehensive physical examination like other case, but there are certain points you need to emphasize when you take the history, if there is recent infection or drug exposure or other relevant factors. In the examination, it's very important to check the blood vessels and also to check peripheral pulses and looking for or listening carefully for bruise, means there is abnormal sounds around the vessels, mainly like carotid or renal artery. If there is vasculitis or affecting these medium or large vessel properly, you will hear abnormal sounds like murmur, but we call it bruise. You need to look carefully for the skin. If there is any painful nodules, purpura, ulcers, microinfarction, or livido auricularis, all these can be a clue for systemic vasculitis. Sometimes the vasculitis is simple and everyone can appreciate it and probably can tell the prognosis will be good, such HSP. In most cases, they have good long-term prognosis, but it can be something like this, either for ischemic digits or the large vessels. As you can see here, the aorta is affected, there is stenosis and post-stenotic dilatation, and you would expect this patient present with refractory hypertension, or it can be affecting the lung, like cavitation and hemoptysis, like in venous vasculitis, may end with stroke presented with now for the lab result, the lab test, unfortunately, we don't have diagnostic test, but the CBC or the routine labs, it may give you a clue. CBC differential is important, but you may see normal white cell count, you may see leukopenia, you may see leukocytosis, Kawasaki disease, typical with normal white cell count. They may present, vasculitis may present with thrombocytopenia or thrombosis. It's expected to see, but we know these are non-specific. Sometimes the hepatic and renal profile affected based on the organ involvement. Now, people are all the time looking for autoantibodies, but I can assure you these are not diagnostic, even ANCA, because ANCA, you may see it in different type of vasculitis. Yes, there is one, especially in adult, called ANCA-associated vasculitis, but ANCA, we know it, there is B ANCA, C ANCA, and these ANCA, you may see it in even other diseases, like ulcerative colitis, you may see C ANCA or P ANCA. In Kawasaki disease, you may see P ANCA. You may see in HSP P ANCA as well. So these are non-specific, but it may give you a clue. But again, these are non-diagnostic. ANA complement may give you a clue if there is underlying disease, especially like SLE. It's very important to do some test or lab test just to monitor or to look for organ involvement. One of the important organ, all the time we are keen to investigate for the kidneys, for urine analysis, looking for hematuria, proteinuria, creatinine ratio is important. Imaging is very helpful in vasculitis, especially ultrasound, Doppler ultrasound, and sometimes we need to proceed for more advanced studies like CT angio or MR angio, or sometimes conventional angiogram, especially if we're looking for the small or medium-sized vessels. Probably you will see some abnormalities like beading or aneurysmal or stenosis. Now, all these probably non-specific. Unfortunately, it's not diagnostic because there is some entities, it may give you the same findings, but these are none or these are not vasculitis. So the bottom line, you need to collect the clinical, including history, physical examination, and laboratory imaging to make a diagnosis of Kawasaki, of vasculitis. So one of the important tests is the tissue biopsy, but sometimes it's difficult. If the organ is easy to biopsy, like a skin, it will be easy. Sometimes the kidney, we can biopsy it. Lung, sometimes you can, but if it's in the brain, it's very difficult. And all the time the neurosurgeon are reluctant to do biopsy. So yes, we need tissue biopsy for all cases of vasculitis, if it's possible, to confirm the diagnosis. Now, what are the clues suggestive of vasculitis? Patient sometimes present with unexplained multi-system features like fever, weight loss, skin rash, hypertension, edema because of kidney involvement, arthritis, neurological like mononeuritis multiplex, focal lesions, and sometimes pulmonary infiltrate or hemoptysis or GI bleed. All these can be, or stroke, headache, So you can see all the manifestations are present in vasculitis. For the test or investigation, again, these unexplained test indicative of inflammation, need to consider vasculitis as one of the differential. You see high inflammatory markers or anemia, leukocytosis, leukopenia, eosinophilia, thrombocytosis, thrombocytopenia, sometimes low albumin indicating renal involvement, or hematuria, proteinuria. These may suggest vasculitis. Now, I said vasculitis is an umbrella. You need to pinpoint specific diagnosis. So if you say vasculitis and stop, this is probably it's not enough. The same like you said, infection or malignancy. You need to pinpoint what type of infection, what type of malignancy, and the same thing for vasculitis. You need to mention what type of vasculitis. There are some conditions mimicking systemic colitis, like antiphospholipid syndrome, like atherosclerotic disease or sickle cell disease, fibromuscular dysplasia, or maybe the secondary causes like systemic disease. Yes, they may present with vasculitis, but it's not the diagnosis. SLE is the diagnosis may associated with vasculitis, but I'm talking about the primary vasculitis. Now, you can see that there is wide range of potential differential diagnosis and non-specific tests, and even ANCA all the time linked to vasculitis, but I can assure you it is helpful, but it can be over-interpreted, so you need to take it carefully or interpret it carefully in the context of the clinical setting. So probably now this is the background. I need to mention it. So please, if you have any question or comment, I would like to hear it from you before sharing a few cases with you. Feel free. Probably what I said well known to you, but I would like to hear from you if you have questions or comment.
معذرة دكتور, البيوبسي in this case is helpful or no?
دكتور أنا ما أسمع الآن.
ما أدري تسمعوني الآن يا دكتور؟
إيه أسمعك يا دكتور, تفضل.
البيوبسي is helpful to diagnose vasculitis?
Yes, it's the gold test for vasculitis. All the time, if you can do it, it's highly recommended, especially for organ easy access like skin. For instance, if you have a patient with unexplained fever, high or abnormal labs, and the patient has skin manifestation, it's very helpful and recommended to do skin biopsy. This will give you a clue for sure, yes. And it will help you, especially if the histopathologist is aware about the clinical manifestations or have clinical data. Probably he will tell you what type of vasculitis, like beginners or in the aorta, nobody will biopsy it. If in the brain, again, it's difficult to biopsy it. The ideal thing, you need to do it, but sometimes your colleague from other specialty, they will not do it, like a vascular surgeon or a neurosurgeon, they will not do it. طيب, probably I'll just share of. اتفضل يا دكتور, أنا ما أشوف معلش. Please tell me if there is any question.
نعم. إذا في disproportion between ال ASR and C-reactive protein, is that indicate vasculitis?
Again, it's not that helpful. I can use this especially in lupus. If the ESR high and CRP is not high, this is maybe disease activity. All the time, CRP probably in favor of infection, but it's not that helpful. You may see it both high, or one is high and the other within accepted range. But again, it's not diagnostic. I can assure you there is no diagnostic test for vasculitis. You need to put everything together, the clinical, labs, imaging, and if tissue types. Now, there are, probably will share some of these criteria. It's not diagnostic. These are classification criteria, and I will just highlight the difference between diagnostic and classification. Diagnostic means if the child or the patient met these criteria, mean this it is a diagnosis. But in rheumatology, we don't have diagnostic criteria. All what we have are classification criteria, means just to differentiate it from others, and mainly for academic and research purposes. It will help you, but it's not for diagnostic purposes. And we will see it in the first case, probably you can see it. Can I proceed, Dr. Ahmed?
نعم تفضلوا بروف.
طيب, this is the first case. I'm sure everyone can make a diagnosis. This is an 18-month-old boy admitted with a 9-day history of persistent fever, poor feeding, irritability. He had swelling of the hands and feet, leukocytosis, neutrophilia, anemia, thrombocytosis, and low serum albumin, high inflammatory markers, ESR and CRP. And he showed partial response to antibiotic. One will diagnosis. طبعا انا ما اشوف الشات اذا حد كاتب شيء.
بعض الزملاء، نعم بعض الزملاء 3 إلى الآن قالوا كوازاكي. دكتور حسين أيضا.
أحسنت. So this is a classic presentation of Kawasaki, but presentation in viral infection. You may see it because you didn't expect to see a response for antibiotic with viral infection, but you can argue viral infection will not give you leukocytosis, neutrophilia, and thrombocytosis, but still there is a chance to be not Kawasaki disease. Now, the clinical manifestation, if you applied the classification criteria, for sure he met the classification. I keep saying, repeating classification, not diagnostic. You met the classification criteria of Kawasaki, and you need to treat with treat him as a Kawasaki. Now, I put here low serum albumin, and anyone can tell me what is the importance of mentioning low albumin in this case? It's expected to see leukocytosis, neutrophilia, anemia, thrombocytosis. This is the classic lab result with high inflammatory markers. But again, you see with albumin, high liver enzymes. Now, serum albumin in Kawasaki patient behave or act like negative acute phase reactant, means with high inflammations or high inflammatory process, albumin, okay, while the acute phase reactant will be high, like ESR, CRP, or it can be like capillary leak syndrome, because of severe systemic manifestation, the albumin will be in the extravasated tissue, and the patient present with edema. All of us know how to treat Kawasaki. Typically, we need to give IVIG 2 gram per kg as single dose. It's superior to divided doses. So the recommendation to give only 2 gram per kg of VIG. For the aspirin, typically we in the textbook, people mentioning to give high dose of aspirin, which is anti-inflammatory dose, around 90 milligram per kg in divided doses. Now, this is the point I'm emphasizing. If you see a patient with low serum albumin, please don't give high dose of aspirin, because we know aspirin is binding to albumin. If the albumin is low, means the free part of aspirin will be high, and it may cause side effect from aspirin. So it's not recommended to give high dose of aspirin in presence of low serum albumin. Now, do you know what are other modality of treatment for Kawasaki? The classic approach, give IVIG 2 gram per kg, then aspirin as anti-inflammatory maybe for 1 or 2 days until the subsided. Then you will keep a patient on anti-platelet dose of aspirin. Your patient is not responding to IVIG. What is
الإجابات في الشات يا دكتور، المثال بريدنيزولون والبيولوجيكال تريتمنت.
أحسنت. So I will skip it. الزملاء they know. لكن as we know, Kawasaki disease, it may be complicated by coronary aneurysm, but in certain conditions, Kawasaki disease may present myocarditis. So if you face a patient with myocarditis, probably you will make corticosteroid or methylpred as a first line treatment instead of IVIG, because we know IVIG, you will give high volume. You don't want to compromise the cardiac function with high volume. You need to give high dose of steroid first, then you can give later on. I hope clear. Now, this is a second case. A 10-year-old girl presents with a history of frontal headache, nausea, vomiting, and abdominal pain accompanied by photophobia. She has severe hypertension, as you can see, very high systolic and diastolic blood pressure. And she has also systolic murmur over the abdomen and both carotid arteries. She had negative history for vascular, hematological, or autoimmune diseases. Her labs evaluation is significant for normal CBC differential, normal renal hepatic profile, normal acute phase reactant, negative evaluation for hypercoagulable state, and negative ultrasound Doppler of the internal carotid artery showed bilateral narrowing 80%. So any thoughts about the diagnosis? الدكتور وليد كاتب بوليارتراس نودوزا. SLE HSB SLE. طيب بس عشان الوقت يعني let us analyze الداتا اللي موجودة. She presented with CNS, mainly headache, and phobia, maybe due to hypertension. This is, she has systolic murmur and narrow. So what is significant in the story, this patient? She has normal lab, including inflammatory markers and negative autoantibodies. So you cannot make a diagnosis of SLE with negative autoantibodies. So I cannot imagine SLE with negative autoantibodies. If زميلنا اللي ذكر HSP, we have large vessel vasculitis. This is not HSP. Polyarthritis nodosa, typically they have leukocytosis, thrombocytosis, and high inflammatory markers. So what is the more important findings? Hypertension and internal carotid arteries. So let us take more investigation, and they did intra-arterial angiography of the carotid arteries, revealing beading appearance. Beading, this is the one. I hope you can see it. There is narrowing dilatation, and this is what people call it beading, the same here. Okay, so any thought? Takayasu, Dr. Walid is thinking about Takayasu. So patient present with hypertension with large vessel involvement. But what is against Dr. Walid Takayasu? خلينا نشوف السؤال هنا. What is the likely cause of medical condition? Dr. Walid, giant cell arthritis. You remember what I said in the introduction? She's a child, fibromuscular dysplasia, sweet syndrome. يعني حتى بس نقربها لكم شوي، حطينا الاختيارات هذه. دكتور وليد، ما زلت مصمم على التكاسل ولا؟ طبعا التمبرال ارترايتس هي للجاينت سيل ارترايتس دكتورة ليلى. لكن probably you heard in the introduction giant cell arthritis or arthritis not exist in children. This is not this. We shouldn't children. So B is out. دكتور وليد صالح muscular dysplasia. الجواب الصحيح مثل ما ذكر الدكتور muscular dysplasia. لكن what is against Takayasu? The clue here إنه طبعا it's not for diagnosis. Like I cannot imagine Takayasu disease with normal inflammatory markers. All Takayasu patients, they have high ESR. So if you see a patient with large vessel involvement, even with hypertension and normal ESR or CRP, this is, and probably as Dr. Walid Saleh mentioned, fibromuscular dysplasia, this is congenital findings or disease. So this is one of the vasculopathy rather than vascular. إذا في أي سؤال حول الكيس هذه ولا we can proceed for other case. طبعا let me just remind you about the classification. As you know, the classification based on the size of the blood vessels. It can be capillary, arterioles, or small arteries, large or medium venules also involved. But again, for Takayasu, you need to see it with high inflammatory markers. And again, these are the breast or pediatric rheumatology European Society classification, and based on the large vessels are medium or small vessels, or it can be other like Behçet disease. And all these have been published and validated, but again, these are classification rather than diagnostic. طيب. Case number 3, this is a 10-year-old boy experienced or an ophthalmologist, which is this one. So this is the oral lesions he used to have, but he came with headache, poor vision for the last 6 months, seen by ophthalmologist and examined, and he found these findings, and he contacted you to help him. His workup revealed leukopenia, elevated ESR, and because of the headache, he underwent brain imaging. It showed sagittal sinus thrombosis. So كان الدكتور عبد الحكيم يساعدنا عاد حول الحمى هذه. اللي it can
Behcet disease.
أحسنت. So this is Behcet disease. You see or heard about sagittal sinus thrombosis, you need to think about Behcet disease. And interestingly, it can be the only clinical manifestation. So if you see a patient with sagittal sinus thrombosis, no other manifestation, consider Behcet disease as a differential diagnosis. Of course, you need to take detailed history, examination, and labs, but put Behcet disease as a differential diagnosis. I put this case not for a diagnosis, but I have another story or scenario, make it more complicated. So the sagittal sinus thrombosis was confirmed. 4 weeks, they labeled him as Behcet disease. And 4 weeks later, he presented with abdominal pain, hepatomegaly, and elevated liver enzymes. So the most likely cause of the new findings is occlusion of the hepatic artery, viral infection, because he's immunocompromised, Budd-Chiari syndrome, or autoimmune hepatitis. شوف الشات في شيء. A, B, C, D. Sent. This is Budd-Chiari syndrome or a complication. This has happened with, it's not uncommon to see Budd-Chiari syndrome with the Behcet disease. Now, it's a bit so please make sure when you read it, you can choose the proper. Now, because of the sagittal, those patients are prone to have thrombosis, and already patient has a red flag for thrombosis, which is sagittal sinus thrombosis, and no wonder to have other thrombosis if he is not treated properly. So the answer is Budd-Chiari syndrome. Okay, the fourth case. إذا طولت عليكم ترى ممكن نوقف في أي وقت.
بالعكس احنا مستمتعين يا دكتور، الله يحفظكم.
الله يحفظك. طيب this is a 4-year-old girl present with 1-day history of added weakness. She also has painful nodular lesion on her lower lab investigation or evaluation for normal CBC, lymphopenia, no atypical cells on peripheral smear, low serum IgG and IgM levels, elevated acute phase reactant, negative evaluation for hypercoagulable states, normal renal hepatic profile, negative autoantibodies. So the brain imaging, because with right-sided weakness, means she has CN involvement or stroke, let's say. But she has skin lesions in her lower extremities. So means she has systemic disease. So the lab was not that helpful apart from low serum IgG, IgM, and high inflammatory markers, some lymphopenia. Otherwise, everything was normal. So brain imaging revealed the following result. Brain MRI showed acute on chronic small subcortical white matter lesions consistent with Lackner infarcts, means she has previous infarction, maybe was not noticed by the family. And brain MRA, no vascular abnormalities, and cerebral angio showed no vascular abnormalities. So that here she has maybe more than one time of infarction or ischemic changes. Now, because easy to biopsy the skin, they did skin biopsy and it showed necrotizing arthritis of the deep dermis. So there is vasculitis proved by biopsy, arthritis. Okay. So what is the likely cause of her medical condition? This is deficiency of adenosine deaminase, or we call it DADA2, or Fabry disease, or Milas disease. This is in tertiary hospital, you will see such cases. في اختيار ذكروا B, C. طيب I understand this is very يعني rare entity. طبعا الجواب هو A. يسمونها DADA2, the deficiency of the enzyme causing it's one of the autoimmune disease, and they present with recurrent or stroke or thrombosis. So this is one of the vasculitis, but this is secondary type of vasculitis. So the answer is DADA2, which is one of the autoinflammatory. So most of the vasculitis syndromes consider as autoimmune diseases. But with the new entities, we call it autoinflammatory disease. Many diseases present with vasculitis, or let us say inflammation of the blood vessels. So I believe, inshallah, if it's okay with you, next time we can talk in details about autoinflammatory diseases or disorder. And I think this is very important entities for pediatrician and even internist. So vasculitis can be a feature seen with several autoinflammatory conditions like DADA2 or SAVI. Again, this is very rare entities, or Aicardi-Gouttiere syndrome. This is one of the interferonopathies, or haploinsufficiency, call it haploinsufficiency H20. This is considered as monogenic patient disease. So we can talk about it, inshallah, in the future. Now, the classification or the type of vasculitis that I showed you, they don't consider autoinflammatory in the classification. If you read it in details, and they don't mention anything about autoinflammatory disorder or disease, because it's newly recognized and people now thinking about it, and I'm sure this classification will be changed and consider autoinflammatory as one of the causes or underlying cause. So in summary, Vasculitis has a broad spectrum with conditions with diverse clinical presentation. All the time we need to keep high index of clinical suspicion to make a diagnosis. The important is time of recognition and early intervention to achieve favorable outcome. So with that, I will stop. And if you have any question, I will be more than happy to answer.
أسأل الله أن يبارك فيكم.
أرجو أنها يعني نالت شيء من توقعاتكم. الله يحفظك.
وأكثر من ذلك يا دكتور، الله يحفظكم. يعني فتحتوا أذهاننا لأشياء مهمة جدا، الله يبارك فيكم. وخاصة أن التخصص هذا البيدياتريك روماتولوجي عند إيمينولوجي عندنا في اليمن لا يكاد يذكر، ونحيل الحالات إما إلى أخصائيين الروماتولوجي الكبار أو إلى الخارج، وكثير من الحالات يبقوا يدوروا بين العيادات وبين المستشفيات وبين الأطباء بدون أي تشخيص، يعني للأسف.
الله يعينكم. لكن أنا سبق أني قلت للدكتور عبد الحكيم وأعيدها مرة أخرى، أنا رقمي عنده، فأي استشارة الله يحييكم على الواتس ولا الإيميل أكون جدا سعيد إذا أستطيع أن أساعد بشيء.
أسأل الله أن يحفظكم ويبارك فيكم. نفتح إذا تأذنوا في باب النقاش، وإذا تسمحوا لي بأول سؤال.
سم.
كانت في معنا بعض التسميات لبعض الأمراض وتغيرت التسميات، فمثلا الجوفينال إديوباثيك أرثرايتس كانت جوفينال روماتويد أرثرايتس، والاي تي بي كانت اميون وتحولت الى إديوباثيك. هل في مغزى لهذا التغيير، او انه نقل لها من كونسبت الى كونسبت اخر، ولا ايش المغزى من التغييرات؟
والله يا دكتور، هي مشكلة الروماتولوجي ديزيز أو الروماتيك ديزيزز فيها مشكلة كبيرة من ناحية النومنكليتشر وأيضا الكلاسيفيكيشن. جزء منها يعني إذا أخذنا الجوفينال إيديوباثيك أرثرايتس، اسمها القديم كان جوفينال كرونيك أرثرايتس، وهذا كان معروف أكثر في بريطانيا أو أوروبا. طيب، ثم في أمريكا أو نورث أمريكا غيروا الاسم إلى جوفينال روماتويد أرثرايتس. لا هذا الاسم صحيح ولا هذا الاسم صحيح، لكن جزء منها أيضا بوليتكس، حتى في الطب يصير فيها نوع من البوليتكس، فخرجوا بنوع من التوافق أنه يصير جوفينال إديوباثيك أرثرايتس. الآن الجوفينال إديوباثيك أرثرايتس is not a disease, it's not one disease يا دكتور. يعني you know أنها there are يعني maybe 6 subtypes. It's not fair to lump 6 diseases under one name. فمثلا السورياتيك أرثرايتس، الجوفينال سورياتيك أرثرايتس يعتبرونها جزء من الجوفينال إديوباثيك أرثرايتس، أو حتى في السابق الجوفينال روماتويد أرثرايتس. بينما بالأدلت في السورياتيك أرثرايتس مستقلة مختلفة عن الروماتويد أرثرايتس. فنفس الشيء السبوندلو أرثروباثيز بالأدلت هذه انتيتي لوحدها مختلفة عن الروماتويد أرثرايتس، مختلفة عن السورياتيك أرثرايتس. بينما في البيدياتريك احنا ما نستخدم السبوندلو أرثروباثيز، نستخدم ما يسمى بالانثيسايتس ريليتد أرثرايتس، again تعتبر جزء من الجوفينال إيديوباثيك أرثرايتس. You can see إنه النيمز هذه فيها مشكلة بالنومنكليتشر بالعموم. مثلا ال HSB كانوا يسمونها HSB، الآن يسمونها IgA Vasculitis. كثير من السندرومات اللي في الأوتو إنفلام إن شاء الله إذا التقينا في قريبا تجد أنها تعطى بعض الأسماء وتتغير. بعطيك مثال أيضا حاجة يسمونها Chronic Recurrent Multifocal Osteomyelitis. I'm sure أنكم you heard about it. This is one of the autoinflam. This is non-infectious. It is inflammatory bone disease. هذا الاسم هو اللي مشهور. حاولوا أنهم يخرجون، لأنه مو هو بالضرورة أنها تكون multifocal. It can be single site or monocyte. فوجدوا أنهم وقعوا في حرج multifocal و recurrent، فهذا قد ما تكون في كل المرضى، فابتدعوا الاسم CNO Chronic Non-Bacterial Osteomyelitis. طيب ممكن تكون الأوستيومايلايتس non-bacterial مثل fungal؟ Yes it can. ليش فقط تذكر لي نون بكتيريال؟ فكل هذه الأسماء يا دكتور تكون اجتهادات ويكون فيها نوع من التوافق، لكنه for sure إنه there is some confusion about the nomenclatures وأيضا الكلاسيفيكيشن كرايتيريا، وهذه في من كل وقت ووقت يصير فيها نوع من التغيير. معليش أنا أطلت في الجواب شوي.
ربنا يحفظكم إن شاء الله يا دكتور. والزملاء على الشات يشكرونكم بشكل بالغ، ويعبرون عن استفادتهم من المحاضرة
الله
بشكل
يحفظك
كبير.
ويبارك فيك، هذا من لطفكم، الله يحفظك.
الدكتور لجميع الزملاء ينصح يعني فاتح بابه لاستقبال الحالات. إذا أي إنسان منكم عنده حالة يعني تحتاج إلى ديسكشن وكذا، الدكتور يعني عارض علينا المساعدة في هذه الأمور. أنا عندي كانت حالة هي اكسبايرد، يعني طفل عمره سنة ونص، وقد جهزنا الباوربوينت على أساس أن أعملها كيس برزنتيشن وأناقش فيها بعض الدكاترة، ولكن توفى الطفل.
الله
فلعلنا يا دكتور إذا أتيحت لنا مجال أني أرسلها لكم أولا وتشوفوا إذا هي مناسبة ونعمل عليها ديسكشن. هي في الإميون أكثر منها في الروماتولوجي، ونعمل عليها ديسكشن إن شاء الله وتفيدونا بخبرتكم.
الله يحييكم، الله يحييكم يا دكتور.
طيب دكتور، ما أدري كيف برنامجكم في رمضان، إذا حبينا محاضرة في رمضان أو ثنتين في رمضان.
هي ما يخالف، بس تكون طبعا إذا حبيتوا تكون بعد التراويح. يبدو أن التوقيت عندنا واحد، يعني الآن الوقت
نعم،
عندكم تقريبا 10 إلا
الثلث. نعم، نفس الوقت. نعم.
ترى.
فمبدئيا نقول مثلا تكون المحاضرات 10:30 إذا ما كان يزعجكم في السهر، وتكون مدتها ساعة إن شاء الله، مثلا من 10:30 إلى 11:30 إذا التراويح تكملوها في هذا الوقت.
لا احنا عادة نصلي قبل، يعني الصلاة لو كانت 10 يكون جيد، ترى
طيب،
النوم بدري يكون أطيب.
إذا خير إن شاء الله. نعم، إحنا ملاحظين
إذا
يا دكتور أنكم
إذا 10 يناسبكم ما عندي مشكلة
نعم،
في
جميل جدا،
رمضان.
جميل
أبشر.
جدا. ربما
وإذا
يتفق إن
في
شاء الله.
وإذا في موضوع معين يا دكتور
نعم.
تبغون نناقشه، ما عندي مشكلة. تبغون الأوتو انفلام من الآن نتفق عليها. إذا تبغوا الجوفينايل أرثراتس ميميكرز أيضا بتكون زي الحالات
نعم.
نناقشها، ما عندي مشكلة.
طيب، وأيضا موضوع البيروكسي أوف أنون أوريجين، وخاصة من جانب الروماتولوجي والإيمينولوجي.
لا أنا ما أحب أني أتكلم عن الفيفر أوف unknown أوريجين، لكن أنا سأتحدث عن يعني كان مؤتمر عن كان بالانفكشس ديزيز الأسبوع هذا، فطلبوا مني
نعم.
محاضرة عن روماتيك ديزيزز أو روماتيك ميميكرز أوف انفكشس ديزيزز،
مه.
روماتيك ميميكرز أوف انفكشس ديزيزز، فكانت أيضا جيدة، فحبيت أنها تكون أيضا جزء.
نعم، أما هذا
لكن
فعلا يا دكتور.
أتحدث عن الفيفر اوف انون اوريجن كذا، يعني لا أجد
نعم.
أني أنا الشخص المناسب
الله
حقيقة.
يحفظكم ويرفع قدركم.
لكنه أحب أني أتحدث في مجالي حقيقة، بحيث أنه ما أتعدى على الحدود يعني.
الله يحفظكم يا دكتور ويرفع قدركم. احنا إذا إن شاء الله بنتشاور مع الشباب في هذه
أبشر
المواضيع الثلاثة
أبشر،
أو
بس
الأربعة.
لعلك تتكرم، الله يحفظك، وتخبروني وش الموضوع اللي
نعم،
ترغبون
بإذن الله
فيه.
سبحانه وتعالى
أبشر
نراسلكم إن شاء الله قبل، بإذن الله.
أبشر، الله يحييكم يا دكتور.
الله يرفع قدركم يا دكتور ويحفظكم إن شاء
إياك.
الله
الشكر
ويزيدكم
لكم
علما.
جميعا، الله يحفظكم بتواجدكم، وأشكر أخونا الفاضل دكتور عبد الحكيم، الله يحفظه ويرعاه.
آمين. الله يبارك فيكم، والشكر موصول لجميع الزملاء. ونستأذن الدكتور إن شاء الله في رفع المحاضرة. طبعا احنا يا دكتور معنا مشروع تطوعي للشباب سميناه To be fit for pediatrician. أردنا فقط نفع الأطباء البورد والخريجين في موضوع محاضرات الأطفال وكاختبارات وكتب
أبدا
و...
أبدا، الله يقويكم يا دكتور. إذا عندكم اختبارات وتبغون MCQs وشغلات من هذه بالبيدياتريك روماتولوجي، أبد ممنون، الله يحفظكم.
الله يحفظكم ويرفع قدركم ويزيد
الأمر
ناس من
الثاني، ما دامكم تسمعون يعني والكوردينيترز الله يوفقه، ترى عندنا أنشطة من وقت إلى آخر تكون ويبينار، يعني كلها أونلاين. فربما إن اللي عنده انترست يعني نوصل له اللينك أو تنشرونها بين الزملاء، فبيكون جيد الحقيقة. في أشياء يعني نعقدها في السعودية كالبيدياتريك روماتولوجي كلاب، ممكن
مهم.
تحضرون معنا. هي للبيدياتريك روماتولوجيست، لكن لا يمنع عنه الحضور. هي اونلاين. وفي اشياء جيده ايضا انترناشونال، والتوقيت يكون مناسب لبلداننا يعني. فاذا حبيتوا اي احد من الزملاء، بس انا ما ابغى ازعج الدكتور عبد الحكيم، فاللي يبغى ابدا نوصل له في اشياء قريبه بتحصل. يعني الاسبوع القادم في اشياء من هذا كثير الحقيقه. لكن كيف الطريقه لتوصيل او تمرير الروابط او الاعلانات هذه، ابد مستعد فيها.
حياك الله يا
نعم.
دكتور، وشاكر ومقدر، وجزاك الله خير، والشكر لك من الله سبحانه وتعالى، يعني انك باذل رغم انشغالاتك الكثيره في
لا
شيء.
لا، ابد بالخدمه يا دكتور، الله يحفظك.
ارضى عليك والله، يعني ما ننسى فضلك.
انتم صاحب الفضل، الله
الله
يحفظكم.
يرضى عليك، ويعني متحمس انك تخدم اطباء اليمن. هذا من الحمد لله
ابدا، الله يوفقكم
ما عندي اي مشكله، انا ممكن اتواصل مع الزملاء ونوصل لهم اي شيء، او تتواصل مع الدكتور احمد، ما في
اللي
مشكله.
تبغى ابدا. انا بس حتى ما اريد اني ازعجك يا دكتور
لا لا،
عبد
ولا حاجه
الحكيم،
دكتور، بالعكس الواحد يعني
لكنه
الله
انا ممكن
يكون انه يعني
يعني في روابط الان بتحصل يعني خلال الفتره هذه، يمكن خلال الاسبوع هذا القادم، في يعني زي الويبينار، زي الكونفرنس الحقيقه، يعني اكثر من محاضره بتكون. اعتقد انها بتكون في الهند، وفي شيء على الايشن باسيفيك، يعني فيه الرابطه. انا ممثل للميدل ايست الحقيقه فيها، فممكن أمر لكم كل الأشياء هذه. أبشر.
دكتور، الله يرضى عليك ولا يهمك.
خير ان شاء الله. الله
جزاك
يحفظكم ويبارك فيكم،
وقين إن
وان
شاء الله يا دكتور.
شاء الله نرفع تسجيل المحاضره يا دكتور في قناه تو بي فيت على اليوتيوب، ان شاء الله نرفعها.
الله يوفقكم ويبارك لكم
الله يبارك فيكم ويحفظكم ان شاء الله يا
وقين.
دكتور.
حفظكم.
حفظكم الله.
يلا
جزاك
تصبحوا على خير يا أخي، في أمان الله.
ربي يحفظكم ان شاء الله جميعا. شاكر للحضور وشاكر الدكتور عبد الحكيم، ولنا لقاء ان شاء الله باذن الله سبحانه وتعالى. واي عناوين تقترحوها احنا مستعدين نوصلها للدكاتره. والقلب النابض الدكتور عبد الحكيم المهندس، ما ننسى الدعاء لك في كل وقت. الله يبارك فيك، حفظكم الله.
الله، جزاكم الله خير، هذا اقل شيء نقدمه احنا في الغربه، يعني الله يحفظكم، جزاكم الله
في أمان الله، مع
خير.
السلامة.
الله يحفظك.